Are we doing this? I feel like I want to do like the Disney thing. Hey guys, how's it going? Welcome back to my channel, or welcome if you're new here. My name is Stephanie. I'm a doctor of physical therapy, and I created this channel to talk all things hot topics in the physical therapy world. Make sure you hit the subscribe button and turn on notifications to get notified of the latest videos. In today's video, we are going to be talking about, do you lose your knowledge if you are just in one setting as a new grad? Specifically, I am an acute care therapist. I have worked in acute care for a little over 2 years now. My first job after graduating in June of 2019 was actually part-time in an outpatient orthopedic clinic. I took my boards in October and started in acute care about a month later. And what's crazy to me is it wasn't the first time when I started in acute care that I heard people say, you're going to lose all of your knowledge that you just worked your butt off for 3 years. If you're unfamiliar, getting your doctorate in physical therapy is a 3-year program. Typically, there are some combined programs here in the US, but I chose to go the 4 years of college and 3 years of grad school route. So a whole 7 years to get this degree. It's been a long time coming. So do I really lose my knowledge if I stay in this one setting since graduating? The short answer is no. And I personally think that a lot of people who do have this mindset are kind of on the closed-minded side. If you were to take a look at the scope of physical therapy and all of the settings that we can work in, I would say that no matter which setting you go into, none of it's going to be mind-numbing if you're truly practicing to your highest degree. And I say practicing to your highest degree because, as we know, the quote-unquote PT mill that is in a lot of places throughout this country that just sticks their patients on modalities or make sure that they all get modalities and massage or soft tissue, and then they do their exercises that are predetermined on a piece of paper or with an aid or tech. That's what we're trying to avoid, because that's not practicing to our highest degree, and unfortunately why a lot of people also probably think that they can just get exercises online, or physicians can just prescribe certain exercises to all of their patients and it's one size fits all. It's not. So what I will say is that practicing in acute care, I use knowledge from every single class that I have taken as a PT student, and even as an undergrad, which I got my undergrad degree in exercise science. And if you are curious as to what these classes are that I'm talking about, as a physical therapy student, which again is a 3-year doctorate degree, I take classes like clinical medicine and pharmacology, kinesiology, orthopedics, neurology, pediatrics, inpatient care, cardiopulmonary, did I say exercise physiology? There's a ton of them. And how do you not use your knowledge from all of these classes in any setting? So some of the settings that physical therapists can work in are outpatient orthopedics, which is what most people know as your clinic down the street, acute care setting, which is the hospital setting. And if you are ever a patient in the hospital, you may or may not get PT depending on what it is that you're in the hospital for. Also inpatient rehab settings, which you can have rehab, which is 3 hours a day. And then there's also subacute rehab, also assisted living facilities, home health physical therapists, there's pelvic floor, there's cardiac rehab. Can't forget pediatrics, which can be in the school or in a clinic setting, or even come to the home as well. So many different types of things that you can do with this one degree. So when people say that acute care can be either mind-numbing or you lose a lot of your knowledge, that to me, like I said earlier, is very closed-minded. Why is it closed-minded? You just think that getting PT in the hospital is as simple as getting a patient up and walking, then you truly don't understand what the scope of physical therapy actually is. And that's the same thing as if you went to an outpatient clinic and the person just had you do pelvic tilts and clamshells and gave you a back massage and whisked you right out the door. So if you are an acute care physical therapist, it depends on the hospital and the location of the hospital, whether it's a trauma hospital, whether it's in a large city or in a small community. The scope of that PT is actually going to range, but from my experience being in a large city like New York City, the scope of a physical therapist in the acute care setting can range in a plethora of settings. Some of the units that I worked on as an acute care physical therapist range from the emergency department to general surgery, abdominal surgeries, vascular surgeries, amputations, plastic surgery, neuro ICU patients, surgical ICU patients, medical ICU patients, cardiac ICU patients, oncology patients, general medicine patients, and everything in between. It's truly such a large scope, and that's why I think that being in acute care and such an acute medical setting really has you practicing to your highest degree, because you make one wrong move and that patient can end up unfortunately with a fall or in critical care. So being a physical therapist in the acute care setting, I use knowledge, like I said, from all of the classes that I mentioned earlier. And again, I have to be on top of my game if I could be in any of these units on any given day. Being in the acute care setting can be a little bit of a whirlwind and can be a little intimidating at times. And I know I get messages from students all the time talking about how nervous they are because the patients are typically, like I said, in that acute medical care, so they tend to be a little more fragile or medically unstable than if you were to see them in a rehab or outpatient setting. I do want to emphasize though that if you are a student and you do have an upcoming rotation in the acute care setting, you should not be afraid, because your CI or whoever you are under should not who says should not, but they typically will not put you in any unsafe situation. It is okay if you forget material or are unsure what to do in a given time, but remember that anything and everything you do should always be safe, and that is the number one most important thing. Knowledge I use in a typical day in acute care involves a wide variety of things. To start off, I have to chart review a patient. That means I have to understand all of the knowledge and terminology that these physicians and nurses are using in their documentation. I'm understanding the past medical history, social history, and everything in between that is going on with this patient before coming into the hospital, as well as now why they're in the hospital and how it is affecting them, like how it's making them ill. As I'm doing a chart review, I'm reading through these lab values which come from blood work or imaging or other diagnostic exams. I'm reading through the diagnoses, I'm reading through their medications, understanding what medications they're on, how it could possibly affect them physically, and then therefore how it's going to affect them in our session physiologically, so that I know how they or their body will react once we get them moving. Once I do my thorough chart review, I am then coordinating care either with the physician or the nursing staff to kind of understand how this patient maybe has progressed since the last note has been written, whether it was early in the morning or later in the afternoon, to kind of get a better picture of the situation that I'm actually walking into. It could also involve coordinating any medications, like if they're post-surgical, making sure that they're getting the appropriate pain medications, which may help them move a little bit better during our session. Or for example, if they have a history of something like orthostatic hypotension, we are making sure that they're getting the right medications to control their blood pressure a little bit better, and then timing our session appropriately. Sometimes the patient may also be on what we would call, in simple terms, a blood thinner. Sometimes we hold and have to know when to hold if they're getting this medication for the first time, because God forbid there should ever be a fall. We don't want to cause any harm to the patient, like bleeding out. Once we kind of get the okay and everything is somewhat medically stable for us to work with the patient, we have to then be on top of our game to make sure that we are monitoring this patient throughout our entire session. And when I say monitoring, it could be anything like cognitively, it can be physically, physiologically, it's like something like blood pressure. Blood pressure is a huge thing that I think people should even be taking in outpatient clinics or even in home health, but there always could be some underlying condition that may not have been discovered yet. What I do is I take blood pressure in the beginning of our session, and as we move throughout our session, make sure we are monitoring that patient closely, making sure they're not getting dizzy, they're not having any lightheadedness, changes in vision, they're not slurring their speech, they're not having any changes in their strength or anything else that's going on. If they do report any kind of symptoms, we then take their vitals again throughout the session to make sure that there's nothing changing, or then monitor how they're feeling at the end of the session to then make sure that they're back to maybe where they were in the beginning of the session, or if there is a slight change, it's nothing that's too detrimental to their well-being. Changes be warranted based off of their vitals or based off their presentation. We as physical therapists also have to know when and what changes to make accordingly. So I am monitoring if there was a drop in blood pressure, the patient's reporting dizziness, how am I positioning this patient to get them better? Am I notifying the nurse? Does a rapid have to be called? Did the patient go unresponsive? Did the patient fall? These are things that we really have to be closely watching when we're in this type of acute setting. Something that we also really make note of from the chart review, if it's in the chart, because sometimes we get the evaluations early enough where we don't even have the information yet is the patient physically able to move? Are they able to walk? Sometimes we do get elderly patients or people who have had severe injuries before their current hospitalization and they are limited in their movement. So what can they do before coming in, and are they able to do the same thing during our evaluation? If not, how can we get them back or close to what they were before coming in? We really have to understand the demands of what we're asking the patient to do as well. What's also really neat is if we were to work with patients who perhaps have an acute stroke, like in a neuro unit, we now have to give them the appropriate tools to make sure that they are safe to get to their next destination, which sometimes could be compensations or little things in their movement or things like assistive devices, and teaching them how to use them so that they can get from the hospital to a rehab or from the hospital to home and be safe in all of those settings. In a lot of hospitals too, PTs play a significant role in discharge planning, and we are helping the entire medical team make decisions on where we think this patient is safe to go next. That could be making sure that they're going to an inpatient rehab versus a nursing facility versus home or somewhere in between. And how are we advocating for our patients and their mobility, what they're able to do or what they can't do, and making sure that they get there safely. Something that I think needs to also really be emphasized in the mobility aspect of patients who are in a hospital setting is more of that strength and conditioning and strengthening principles. You don't have to know exactly what exercises specifically to prescribe, but it's more so also the capacity. Understanding that your patient most likely, even if they are feeling a little fatigued and weak, they can do something more than just getting from bed to a chair or just walking down the hallway. What kind of balance activities are you having them do? Are ankle pumps really the best exercise for them? Are you loading them appropriately? And I think that that's a principle that gets lost not only in acute care, but in a lot of settings. Are we truly loading these patients appropriately, like to the capacity that they are able to tolerate? So principles that you learn in cardiopulmonary or exercise physiology can really play a huge part in these settings, because you have to understand what the patient and the person in front of you is able to do. My ICU experience is limited, so I'm not going to talk too much about it, but I will emphasize the following. Ever seen a patient that's intubated get from the bed to the chair? I have. It's not an easy task. And sometimes it takes 2, 3, 4 people if you have all the hands. Early mobility is huge, and really I'm so excited it's starting to blossom more and more as the years go on, but it really needs to be recognized because patients, especially coming out of the ICU with post-ICU syndrome, post-intensive care syndrome, whatever you want to call it, super important to get them moving, because the earlier you are mobilizing these patients, the better that their outcomes are. That's a whole other story though. I just want to say that contrary to popular belief, acute care physical therapists played a ginormous role in the COVID-19 pandemic. I myself was in New York City, in Manhattan, the major epicenter, in March 2020, and it has been just a crazy ride to watch everything evolve. We were part of the teams that helped with proning these patients or putting them on their stomach to make sure that they were able to have some assistance in their breathing capacities. I myself had to learn how to handle patients that had tracheostomies very early on because they were overflowing out of our normal ICU unit. Really understand the sensitivity of these patients, what their lung capacities really were, what they can and can't handle. Unfortunately, these patients with COVID were very, very sensitive to movement, and unfortunately we had to do a lot of monitoring, more than just oxygen levels, to make sure that we weren't over exacerbating them, because it could possibly make them take a turn for the worse. I do also just want to emphasize this, as I kind of touched on in the beginning, any setting can really be mind-numbing. And when you're kind of stuck in a routine as a practitioner, day in and day out, doing the same thing, applying every single thing to every patient that comes in with back pain, leg pain, whatever, are you truly practicing to the highest degree that you can? Are you growing as a clinician every single year, making sure that you're staying on top of not just the latest research, but the patient that is in front of you? And I think that is what gets lost in translation often, is a lot of people get so caught up in research or best practice that they're forgetting about the human that is sitting in front of them. That is somebody that is in pain or illness that they want to just get better. Are you listening to them? Are you making sure their goals are specific to them? Are you just giving them generic exercise? So if you currently are a student, or if you're a new grad, or someone who's even been practicing 5-10 years out, I really hope that you take away something from this video, that not only all physios in every setting are of importance, but is anything truly mind-numbing, and what skills are you actually using? Because if you do have the mindset that there is one setting more than the other that is more important, or one that is less mind-numbing than the other, think back to your schooling, think back to your board exam, think back to all of the knowledge that you have been taught and have learned over the years, and how you can apply everything you've learned to one setting. Because I guarantee you that you can take at least 5 things away from every single subject that we have learned in our schooling and apply them to whichever setting you are currently working in. Thank you so much for watching this video. If you have any thoughts or comments, feel free to drop them below, or you can message me on Instagram at dpt.steph. There is a lot of content there for students and talking about what life is in the short form in the acute care setting. Make sure to subscribe down below and turn notifications to get notified every time there's a new video. Thanks so much for watching, and I'll see you soon.